size baskın yaptığı adamları bu teşkilat.
Mute all in here, chat.
Unmute Mr. Master Son.
Now just go on more.
Unmute him.
More, yeah. And make co-host. Okay. Now you might want to just write on a text here. Please.
Where are the other hosts?
They will come. Dr. Sonal, please accept everyone from the meeting.
Hi, Dr.
Hello, PC. Good afternoon.
Good afternoon.
Good afternoon. I'm just waiting for our other guests. I don't see Master.
Dr. Son just went for restroom. He will
No
be
problem.
back shortly.
Master Yo Hongwa. Hello.
Yes.
Our other faculty. I'm waiting for our other faculty.
Okay.
Master Hugh, I don't see him. Master Son, welcome.
How are you?
I'm fine. Welcome to this webinar, sir.
Oh, yeah. Oh, you look very young. Why?
I lost all my hair.
Oh, baby.
Baby. It is fun.
Okay.
I am waiting to, yes. I'm waiting for Master Master Choi. Dr. Choi has also joined us, I believe.
Okay. Dr. Malcolm,
Yes,
is
sir.
there your house or your hospital?
I'm at my home right now.
Oh, home, your home. Oh, beautiful.
Okay, 1 second, sir. Let us get ready and let us start with our meeting.
이쪽으로 오시는 센터.
아니 그냥 여기 있어 여기.
아까 좀 맞춰놨고.
여기 하면 돼 여기. 항상 이렇게.
Now you do keep doing that. Master Son, can we start with your lecture very soon?
Okay. Okay. One question. How long time to lecture?
As much time as you want.
Okay. Thank you.
No time limit. We have no time limit today.
Okay.
We can speak for 24 hours. Our people listening. I'm not able to answer.
Hi, Monster Choi.
Yes, Master Choi. I'm trying to unmute him. Yeah, I've unmuted him. I'm waiting for Master Hyo Dongwa. He has not joined our meeting yet.
Yeah, Dr. Malcolm, Dr. Ho, just 5 to 10 minutes late for his family dinner. So maybe he will come in while Dr. Son presenting.
Yeah, no problem. Master Son, I think we will start with your lecture.
Yeah.
Okay. If you are ready, you are the host now, so you can speak. The screen is all yours. You can start screen sharing.
Okay, can you my slide? Can you?
Yes, yes, yes. We can see it.
Okay. Now, okay. I'm start.
Yes.
Hello,
Please.
everyone. I'm Dr. Son from South Korea, Busan City. Today, my topic is the meanings of UB in the history of spinal surgery. Today content table. First topic is the general stream of surgery. Second, the difference of surgical anatomy. Third topic is UBE is a reasonable endoscope solution for complicated and hard cases. First, you know that general stream is this type. First, open surgery. So after developing antibiotics, good quality metal, stainless steel, titanium, open surgery has developed rapidly. After then, optical lens, microsurgery, optical fiber, endoscopy. Next, minimal invasive concept is developed. Nowadays, some hospitals use the robotic surgery, more accurate, real-time image, less radiation. Next, maybe in future, gene therapy, stem cell, I think. Okay, first abdominal surgery. You know, the first open and microsurgery, there are two types of endoscope. One tube is gastroscopy, colonoscopy, but these tools is very easy, very good diagnosis tool, but this small resection is possible. But different type is laparoscopy. Each system has a multi-portals and most popular, but this can be done, can be done by cancer surgery, big surgery, based on laparoscopy. Nowadays, some hospital, robotic surgery, also this is a multiportal and early stage, but early stage. Orthopedic also is open surgery, microsurgery. Early endoscopy, single portal, diagnosis arthroscopy, but this diagnosis arthros disappeared. But nowadays, arthroscopy has a multiportal. It's very popular. Cavitary, extracavitary. Diagnosis also can do reconstruction. But this topic is spinal surgery, open surgery, microsurgery, but unfortunately, microscopic surgery is the most popular gold standard now. But two-type endoscope, one portal, PLD, PRD, this is a tubular system, but the first target is the discectomy, but now after then, MED, PSLD can do stenosis for endoscope fusion, but UBE is a different system from one portal system, but this multi-portal, one portal system is a tubular system, but UBE is a non-or semi-tubular system. This figure is to show you. This here, left hand take endoscope, right hand instrument. This is working portal. Working portal has two parts. First part, soft and free part, edge open surgery, rigid and lateral tubular system. So this we call this is a tubular system. So this semi-tubular system has no visual, no motional limitation, and same indication in the open surgery. Also less and minimal invasive surgery. But now you know that almost all spine surgeons apply to microsurgery, but endoscope surgery is only about 5% spine surgeon. But UBE is defined endoscope-assisted microsurgery. So UBE has the benefit of microsurgery. UBE is also has endoscopic benefit. So I want UBE, I hope to be conversion of microsurgery into endoscope surgery. And also UV become a cornerstone for robotic surgery, I hope. Next topic is the difference of spinal surgical anatomy. This paragraph is microscope, this is endoscope. You know that the goal of surgery is, first goal is neural decompression. Endoscope also same, but there are big difference. The location of lens and light source is a big difference. This is outside. In microscopy, in endoscope, lens inside and near. So textbook and microscopic anatomists have a very big effort to make approach to. So main anatomy is for approach, but endoscopic surgical anatomy is focused on lesion itself to damage neural tissue directly. So also operating time is different. Operating time is approach and decompression in microsurgery, but in endoscopy, almost all decompression is operating time. Also terminology is different. This is approach, dissecting approach, but this is percutaneous soft tissue. Also bloody operating field, continuous watch them blood rest, but all remember, but disease means disease is the abnormal change of normal structure. Microscope and endoscope also we can treat the disease. So we must check the distorted and change anatomy in preoperative MRI and radiology finding. This is endoscope UV surgical anatomy. It is not to concern big muscle because of transsoft tissue approach. Also, it's to focus on abnormal change in the structure of disease. Also, it is to check under surface of ligament problem due to endoscope mobility. Also, UV can make more clear and watch the operating field. You can see here, this is above ligament problem, but you can see here calcific ligament problem. This figure is under surface of ligament problem. This vein connected the dura to ligament problem. So this is endoscopic surgical anatomy is different from microsurgery. I will show you the endoscopic surgical anatomy for central stenosis, but you in preoperative X-ray MRI, you must check height gap between disc and interlaminar space. Also, you know that multifidus is a very important structure to make stability. So, you know, multifidus is assembly of small muscle particles. Also, interparticular space also important. UVE is through interparticular approach. Also, above lamina, so many bleeding. Bleeding focus is superior articular artery, inferior articular artery, and interarticular artery. Also, rotator longus muscle is very important. Rotator longus muscle attached, inserted to mid portion of lamina. So, insertion medial insertion is medial lateral. So, drilling starting point is medial rotator longus. Also, the shape of lamina spinosa also important. I think the ligament flavum is the most important structure in disease condition. Ligament flavum has a superficial and deep layer, also midline cleft and fiber direction. In beginning period, surgeon sometimes miss the orientation. In scopic field, the fiber multifidus fibers direction is transverse. So you must always check the fibers direction during your procedure. That means here, good orientation make good surgery. Also, ligament flabum attached to anterior surface upper lamina and posterior surface and lower lamina. Anterior surface has a tubercle. Tubercle means the insertion site of multiplex. So, in your operation, you must remove the tubercle, more cranial undercutting. Also, the bony junction between upper border of lower lamina and medial margin of SAP is very important landmark. That means just below bony spur, you can check the root. That means the bony junction means root location. Also, epidural venous fluxus. That means epidural venous fluxus is a microscopic surgical anatomy. But where is the common bleeding focus? The common focus means endoscopic surgical anatomy. There are 4 factor to compressed lemon root here. Hypertrophy, ligament, hypertrophy joint, especially medial margin of SAP, bulging disc, the thickened, marginal annulus bone spur. But first, this is important. No name, the connecting vein between foramen and lateral recess. Sometimes engaged connect vein, the cross the root, engaged cross vein, compress the root. So these all compression factor must be removed in your endoscopy procedure. Last 3 topic is UBE is a reasonable endoscope procedure for complicated and hard cases. These all cases so difficult in microscopy, in endoscopy, in open surgery. But first, multi-level stenosis in elderly patients. The multi-level stenosis is a long incision and big muscular damage, also long time, so difficult. Revision, next revision case. Revision case has a big adhesion, so there are possibility of dural tear and sometimes incomplete decompression. L5 is on extraforaminal stenosis. Sometimes it's a misdiagnosis. Also, each area, this area is very deep and narrow, so difficult, sometimes incomplete decompression. First, central and foraminal combined stenosis means sometimes here heterolysis is possible. Also, retraction injury also possible. 6. Endoscopic lumbar interval fusion for multiple level or adult degenerative kyphoscoliosis. It's also difficult, but you know that almost all spine endoscopy is a beginning period. So also endoscopy lumbar interval fusion also beginning stage. So 1 level endoscopic lumbar fusion is a long time in beginning period. But also many spine surgeons have a poor skill to make a good correction, lordosis and scoliosis. 7. Thoracic, hard and huge disc with myelopathy. It's also complicated hard case. So you know that this is a very difficult approach, possibility code injury. I will lecture the step by step, each topics. First, multi-level stenosis in elderly patient. You know that almost elderly patient has a multi-level stenosis. I think if you are beginner, you have a long time to decompress only 1 level. I recommend you, if you have below 1 hour surgery for 1 level, you try multi-level. So in by expert, 1 level maybe 30 to 50 mmHg. Also, this endoscope procedure, hemoglobin no change, less most damage. Also, patient can work at POD 1 day. You can see here, multiple level preoperative, postoperative here. Next, revision surgery. revision surgery, so many doctors be afraid of the how to remove adhesion tissue, but in conventional surgery, most surgeons try to remove adhesion tissue, but I don't remove adhesion tissue. That means here, adhesion tissue is not to be removed and to be a protector during procedure. This is the first surgery, this second surgery. This is a preoperative MRI. This patient has a severe stenosis with Coda Equina syndrome. So I did the first ULBD, second discectomy. Unfortunately, this time, 2 months later, here more this recurred disc herniation. This patient complained right side more painful condition. I approached the same side here, but this is adhesion tissue. You can see adhesion tissue. This is a preoperative, postoperative, but there is no removal of adhesion tissue. Adhesion tissue act as a protector during my procedure. I approached here protector, right side remove the rupture disc, also left side rupture disc. Here, this is a scopic picture here, adhesion tissue bone here. Only small slip you can do. Also, next important anatomy in revision surgery is the medial wall of pedicle. Here, this is root medial wall pedicle. That means I think I always check the medial wall of the pedicle first. That means this area has a less adhesion. That means medial wall of pedicle means lateral border of the root. So that is the root should be checked at first. This, if you check the root, next step is very safe. 3, the L5 and extraforaminal stenosis. The most important thing is accurate diagnosis. The accurate diagnosis is based on symptom L5 symptom symptom. Also, Allasign Pao band in MRI. Allasign Pao band not published terminology, but this in my hospital we commonly use Allasign and Pao band. Also, I recommend you coronal CT scan help you to check to make accurate diagnosis. Also, there are 4 compression factor, dorsal factor, also ventral factor. Okay, this means here, first this figure is a Pao band. Pao band means some fibers connect to here. Pseudoarthrodesis connect to the disc and bone spur. So this Pao band divided lumbosacral tunnel, upper tunnel, low tunnel, root go through low tunnel. So Pao band entrap L5 root. So this is preoperative, postoperative. You can see here, this figure, post-operative MRI show you removable Pao band and you can see pre-root here. Also, this is Allasign. This preoperative MRI you can see here. Right side Allah is very white, but here left side very dark signal. We call commonly dark signal in extraforaminal stenosis. We call this dark signal on Allah area. We call commonly Allasign. This is a post of MRI. You can see a pre-MRI. Also, always so. Also, this figure, commonly I mentioned here, there are 4 factor, ventral or dorsal factor. If you want to go ventral area, you must learn the Songe triangle. That means here, this is transverse plus Allah here. This is root. The medial part of root is the Kenbin triangle. Lateral part is here, Songe triangle. This is transverse is cutted transverse process, low margin, and here lumbosacral tunnel, here the lateral, root to lateral, this is Sonju triangle, this is here. Through this Sonju triangle, I can remove ventral portion, bulging disc, bony spur also, far out bend, I can remove. Next, central and foraminal combined stenosis. This condition is very common. This condition commonly performed through contralateral approach. If contralateral approach can decompress contralateral to root ipsilateral one root. So there are three subtypes: sublamina, interlamina, translamina. This is preoperative MRI. So severe central stenosis with left foraminal stenosis. This is a post-operative MRI. This yellow arrow is the operating direction. So central and foraminal direction, full decompressor. This is schematic figure is here. Red dot is the initial target point. The height line is medial wall of pedicle. So this vertical small two line height line is general portal marking bar. This is a target. Target is here, foramen or foramen and here lateral is so the operating direction this type. So the two portals move the more caudally here. This red line, vertical red line is a modified portal this type. So this one upper contralateral root, this lateral root, ipsilateral root, three root compressed using contralateral approach. Next.
Sorry, we cannot hear the voice. Dr. Sun, you are muted.
Please unmute your.
Master Son?
Dr. Sun, you're muted. Yeah, we cannot hear you about 1 minute.
Okay.
Yeah, Master Son is on.
Yeah, I'm going. I'm continue. So this one here, this this condition is L23, severe herniated disc. This is preoperative, postoperative. This is preoperative, postoperative. The operating direction, this one. So this type, narrowing high lumbar and narrow lamina, I performed through transforaminal approach this type. I commonly use 0 and 30-degree endoscope. In this condition, for this condition, you must remove the first internal decompression. Next, rupture the disc to only push it down. So this is to prevent the root and cord damage. To prevent cord damage. This one, transforaminal approach schematic figure here. Also, red dot is isthmus is the initial target point here. This one, 1 centimeter lateral line. This is 2 or 3 centimeter lateral line. This line and the midline 2 height line is general portal port. But this case is you must go ventral portion of sacral sac. So, the working portal and portal, modified portal more laterally here, 2 or 3 centimeter lateral initial. Also, this portal more cranial. The operating direction this time, if you this original general portal, you can remove the more SAP. Sometimes instability possible. So, two portals more lateral, more cranial is important. Next, endoscopy lumbar interval fusion for multi-level and adult degenerative scoliosis. You must in conventional surgery, in endoscope surgery, fusion surgery, fusion. So to increase the fusion rate, you can make bleeding end plate also much more harvestable. Also, to make correct big lordosis, correct good correction, how to make big lordosis. The key is first, you must check the disc angle. Also, cage size location. Where is the location of cage? Also, screw and reduction technique you must learn. Also, maybe I recommend you first a simple level, simple one level, single level fusion. But if you master one level fusion, you can do multi-level also deformity. Here, in my case is 90 minutes per level. This is a serial fusion. Also, this patient is, you can see here, adult degenerate kyphoscoliosis. This is a preoperative, postoperative, very good induction. Last one is a thoracic hard and huge disc with myelopathy. I used through modified lateral extracavitary approach. Also, I use 0 and 30 endoscope. I tried to remove first internal disc and marginal bone edge of disc at first. Next, remove the rupture disc here. This one here. Compression, old compression fracture, huge ruptured disc extruded and cold compression. This is preoperative, postoperative. Here, axial view, preoperative here, core damage. This direction is the operating direction. This direction is the modified lateral extracavitary approach. Okay. Okay, do you agree this sentence? Better patient care is a doctor's future. Hey, Malcolm, do you agree this sentence?
I thoroughly agree with you, sir. Thoroughly agree with you.
Okay. Until now, traditional care also, but from now, ERAS, you know, the ERAS concept enhanced the recovery operating time. So until now, decompression surgery, destructive surgery, disease-oriented surgery, doctor side surgery itself, but from now, functional, less invasive, symptom-oriented, and patient side. I want the better patient care make my future. I think my conclusion and our future. Everyone, let's think about what should I do for better patient care. Also, what should I do for coming post-revolutionary period? Thank you, everyone.
Fantastic, fantastic, Master Son. A beautiful lecture by you. We will request you now to stop your screen sharing. It's really a fantastic lecture, mind-boggling. And you have put a perspective on UB in a complete manner. Today, you have showcased everything that we are believing in, but are not able to showcase, and you have showcased everything for us today. So a question to the audience, if anybody has an audience question, we can entertain a question or two, or else I will request Master Dong Wahio to continue with the next lecture, and then we will take the question and answer session. So can I request Master Hyo to start his lecture now? Unmute himself and start his lecture. Master Donghwa Hyo, we are waiting for you, sir.
Yes. Okay.
Good. Can you share your screen with us, please?
Yes. Can you see my presentations?
Yes, absolutely. Wonderful.
Okay. Okay. I start. Please wait. Thank you, Chairman, especially Professor Malcolm. Thank you for the invitations today. Today's my time. I'm Dong Wah-ho. I'm working in the Seoul Bumin Hospital in South Korea. today's my topic is the UV approach for the treatment of lumbar-foraminal and extraforaminal lesions. So today my presentation is focused on the video presentations. Okay. The research approach is firstly performed by Dr. Wills. So basically, UVE paraspinal approach is the technique is very similar to the microsurgery. So we can treat the foraminal, extraforaminal region successfully using the UVE. So the skin incident point of the paraspinal approach using UVE, in AP view, lateral border of the pedicular line, the laterally 1 centimeter to or 2 centimeter laterally. So in lateral view, based on the pedicle or foramen, in mid portion of the foramen, 1 centimeter upper and 1 centimeter below. The dominant hand is right side, so left hand is the left side is made for the working endoscopic photo. The right hand is used for the endoscopic photo like this. So UVE approach is two-hole triangular approaches. So final view of the AP, lateral view of the after making two portal. So that is the docking point of the two portal. I usually making two portal and meet two portal together over the transverse process. And firstly, I dissect transverse process lower level and then move to the isthmus and move to the lateral border of the spinous process, SAP. So that is my first approach into the around the foramen. So the most useful surgical landmark is the tip of the SAP and the lateral border of the SAP. So firstly described by the Dr. Son. So if you find the tip of the SAP or lateral border of the SAP, you can do a paraspinal approach using UVE successfully. So that is the intraoperative, the endoscopic view, the left side approach. This is the lower border of the transverse process. This is isthmus and the lateral border of the SAP. This view is very similar to the microscopic view. And then the removal of the lower border of the transverse process, and you can detach the bony structure from the foraminal ligament. You can see the epidural fat. After removal of the foraminal ligament, you can see the epidural fat and neovascularizations, as well as the adhesive tissue. After removal of the disease adhesive tissue, you can easily find the external oblute, and you can see the disc space. Now I show the real operation videos. I used using RF, the dissection of the lower border of the transverse process and removal of the lower border of the transverse process and around the mammillary process. And you can see the foraminal ligament. And this portion is the isthmus, lateral border of the SAP, superior articular process. And we can detach the foraminal ligament from the SAP lateral border and removal of the foraminal ligament. You can see the epidural fat, neovascularization, and adhesive tissue. If we remove of the adhesive tissue, some bleeding occur. We can easily control by the RF probe. After bleeding control, you can see the clear external oblute. Can you see that the external oblute? This is the disc space. and you can additional decompressions or you can do the discectomy additionally. That is the final view of the complete decompression after extending lobe root through the paraspinal approach using UBE. I like to show the first case. This case is the man presented with severe left-leg pain. You can see the foraminal disc herniations, and you can see also herniated disc located at the extraforaminal area. Also, you can see the calcified disc herniations. So my choice is the UBE approach through the paraspinal approach. After removal of the foraminal ligament and adhesion tissue, you can see the very swelled lobe root, very wide and swelled. And between the extending lobe root around the disc space, severe adhesion. So I carefully dissect and I firstly remove of the soft disc herniations firstly. This is the extending lobe root. I did internal decompressions firstly, and I removed the soft disc herniation firstly. And then I dissected between plan, extending lobe root and disc space for the removal of the hard disc herniations. So yes, now I remove of the calcified disc herniations and dissect ventral portions using the, yes, finally I remove of the calcified discs. That is the final view. You can see the extending lobe root disc space. The post-operative MRI, you can see the complete removal of the foraminal disc herniations as well as calcified disc herniation, and we can minimize the bone for the decompression of that regions. And next topic is the extraforaminal entrapment of the L5 lobe root. Some doctors say the far out syndrome, some doctors say the Bell-Tortis syndrome. Also, we can treat that persons using the biportal. The extraforaminal entrapment of the L5 lobe root can be treated by UBE. I just showed my second case. This patient presented severe left leg pain. So in our institute, we usually check the oblique foraminal MRI. If we can check oblique MRI, you can see the foraminal disc herniations, and you can see the pseudoarthrodesis between the ala and transverse process. And you can see the pseudoarthrosis. So my choice is the biportal endoscopic surgery. So firstly, make the temporal based on the mid portion of the foramen. Left side approach, you can see this is the hypertrophy, the transverse process, and this portion is mammillary process. Maybe this portion is ala. This portion is isthmus. This portion is the lateral border of the superior articular process, and then removal of the lower border of the transverse process, mammillary process, firstly, and then the removal of the lateral border, the SAP. This is the lower border of the transverse process, and you can see the SAP, very important, the surgical landmark. If we remove the lateral border of the SAP, we can detach the foraminal ligament from the bony structure. After removal of the foraminal ligament, you can see the L5 lobe root, firstly. And this patient also has discal herniation. So after decompression and exposure of the L5 nerve root firstly, and then removal of the soft discal herniations. And then now I dissected the pseudoarthrosis area between the hypertrophied transverse process and ala. I drilled out the ala. This is the pseudoarthrosis portion. This is hypertrophied transverse process. You can see the pseudoarthrosis. And around that portions, you can see the severe adhesive tissue, and sometimes you can meet the neovascularizations and inflammations, and removal of the depression. This portion is extraforaminal area and perilateral portion. This is the ala, and the removal of the ala and adhesive tissue and band. We can decompress more laterally, more distally. Also, we can remove of the soft disc herniations. So that is final view. We can achieve long track decompression of the L5 external lobe root from proximal to distal portion. The Dr. Son already said, presented pre-ganglionic, ganglionic, post-ganglionic portions. That is the pseudoarthrosis area, fully decompressions. And you can see it's the pseudoarthrosis area, transverse process, and ala. We have to decompress this area for the complete decompression of the far out syndrome, long track decompressions, pre-ganglionic, ganglionic, post-ganglionic. So post-operative MRI, we can see the complete removal of the foraminal and extraforaminal discal herniation. Also, we remove of the arthrodesis between ala and transverse process. So firstly, we have to expose over the proximal end of the L5 nerve root, because sometimes we meet the dual nerve root. This patient has the triple nerve root. There are the high possibility of some possibility of the variation of the external nerve root. So we have to firstly decompress proximal area of the L5 external root, and then move to the more distally. So that is very important point of the L5 extraforaminal intramural syndrome. And sometimes we meet the patient with the double crush syndrome. In cervical cases, sometimes some patient has the cervical radiculus as well as median nerve intramural carpal tunnel syndrome. In lumbar area, sometimes, especially elderly patient, have the central lesion with the extraforaminal lesions. This condition is sometimes the one of the lesion of the failed back surgery. So double crush syndrome of the L5 nerve root, the firstly compressed and the intraspinal zone, and secondly compressed the extraforaminal zone. So I'd like to show my case. This area, the L45 axial image, you can see the severe lateral recess and central stenosis. Also, this patient has the L5S1 far out syndrome. So my diagnosis is the double crush syndrome of L5. You can this is the left side foraminal view. You can see the no indentation of the L5 root. In contrast, you can see the severe indentation of the L5 nerve root, and also you can see the pseudoarthrosis between the transverse process and ala. Therefore, my plan is, firstly, I decompressed L45 ULBD using the hypotendoscopic surgery. This surgery is very common procedure. Now I decompressed L5 traversing nerve root through the L45 interlaminar space. So I firstly decompressed L45 area, central and lateral recess area. You can see the central area contralateral traversing root ipsilateral traversing route. And then I move to the L5S1 paraspinal approach. That is the important landmark SAP lateral view. This portion is the pseudoarthrosis area between the transverse process lower border and ala. We have to remove, you can see the pseudoarthrosis area. Firstly, we have to find the proximal portion of the L5S1 lobe, and then we move to the distally, and we decompress more distally. I completely remove over the pseudoarthrosis area, proximal, preganglionic, ganglionic, postganglionic. So, final view. Firstly, I decompressed L5 lobe 2 traversing area at the L5, and I moved to the paraspinal approach, and I decompressed L5 lobe 2 from preganglionic to postganglionic. This is the L5 post-MRI show the completely decompress the central lesions, and also you can see the foraminal area decompression status. So if you diagnose the double crisis syndrome of L5 lobe 2, UBE can achieve optimal decompression. So optimal decompression leads to the good surgical outcome. Next up is the contralateral approaches for the foraminal regions. I prefer the contralateral decompressions using UBE. So I just showed my case. This case is first case is the foraminal disc herniation with the concomitant lateral recess stenosis. This patient has the claudications. However, recently his leg pain was aggravated. So you can see the L3 pro lateral recess stenosis with the right side foraminal stenosis, foraminal disc herniations. So my plan is the contralateral approach. Left side to the right side. This is midline laminotomy, and I'll remove the contralateral right side ligament flavum. This procedure, very common procedure for the UBE surgeon. So after removal of the contralateral ligament flavum first, and you can see the traversing of the L4. This is medial border of the pedicle. And if we move to the foraminal ligament more superiorly, more cranially, you can see the foraminal disc herniations and removal of the foraminal rupture disc herniation. We can see the L3 exiting lobe root. This is this disc space, and L4 root. We can decompress the dual root through the contralateral sublaminar approach using UBE. So you can see post intraoperative UBE scope visions presented as complete decompressions of L3 exiting lobe root as well as L4 traversing lobe root. So, and also this portion, there was located the rupture disc herniations. So in my opinion, based on the middle portion of the pedicle, more lateral portion, the paraspinal approach is better than the contralateral approach. Some concomitant central lesion and below the middle portion of the pedicle line, the contralateral sublaminar approach sometimes better than the paraspinal approaches, just in my opinion. So you can, if we use the contralateral sublaminar approach, you can achieve complete decompression of the exiting lobe root as well as the traversing lobe root. These pictures, the intraoperative C-arm view in my operations. So, in my conclusion, bipolar endoscopic surgery can do many kinds of the lumbar degenerative disease, especially if we use UBE approach, we can completely decompression and resolve foraminal and extraforaminal lesion. The indications, so the foraminal lesion, extraforaminal lesion, soft disc herniation, as well as hard disc herniations, calcified disc. For our syndrome, also the indication of the UBE, double cross syndrome, also one of the indications of the UBE. So if we use the UBE approach, we can do full decompression like open surgery or microsurgery. The UBE is powerful surgical method, my opinion. Thank you, all audience, and thank you, Malcolm, and thank you, Master Song. Thank you.
Thank you so much, sir. It was a very, very wonderful presentation, especially your initial presentation where you showed us how exactly to do the extraforaminal approach and do a para-UB. That was a very wonderful video, sir. I think everybody enjoyed that. I will ask the audience whether they would like to go ahead with 1 or 2 questions right now, or shall we go ahead with my talk so that we can move a little faster. I think I have given all the speakers enough time to speak whatever they wish to speak. So if you do not mind, I will now proceed with my own talk.
Malcolm, I would like to ask a question to Dr. Dongwa. It is regarding the placement of ports in right-sided approach for the paraspinal UBE. Any tips or tricks which you use? Because being a right-handed surgeon, it is easy to operate on the left side of paraspinal lesion. But in case of right-sided paraspinal lesions, it becomes a little cumbersome to approach the area.
Yes. In the right-handed surgeon, the left side approach is more comfortable. However, the paraspinal approach, we have to do the patient dominant side. So if patient have the left side foraminal region, so we have to operate it right side. However, sometimes L5S1, if patient has high iliac crest, sometimes the high iliac crest the interfere the approaches. However, the position is important, and we just move the 2 hole should be made more cranially, and we have the approaches so more the caudally. So right, this direction. So in beginner's period, that operation is sometimes very difficult. However, if you have many experience of the UBE, you can do. And also, the first docking point is the transverse process. So some doctors prefer the isthmus, some doctors over the facet joint. However, some might prefer the docking point is spinous process of the lower border. So we can expose the isthmus SAP lateral border without expose of the total facet capsule. So left side or right side is okay. Okay, yes, that is my answer.
Okay, and my name is Dr. Tanzan Naim from Myanmar.
Yeah.
Can I guess one question that Dr. Tom for? Yes. Okay.
Yes.
Yes. What I would like to know is that you in the extra paraspinal approach to prevent the retroperitoneal correction of the fluid.
Fluid, yeah.
Yes, I would like to know your suggested tips and tricks and precautions how to prevent this complication.
Yes. Yes. So the especially L4-5, L3 area, some in beginners period, some doctors approach very laterally. So the fluid dialectic inflow into the intra-abdominal area. That is very severe complication sometimes. So we have to firstly see the bony structure as well as the ligamentous structure. So there are very, very low possibility of the intra-abdominal fluid collection. So however, if you see the muscle layer, muscle fiber, mainly you can see if you do the very laterally. So it is problem. So we have to see always see the bone and the ligament structure firstly, foramina, lateral sleeve of the ligament flavum, and especially L5S1, there is very low possibility of the fluid collection. However, if patient has the far out syndrome, if we have to do remove of the pseudoarthrosis area, if we the pseudoarthrosis area completely, the destruction of the barrier between the spinal area, paraspinal area, and so there are possibility of the fluid collection. So we have to finish until just my opinion, 30 minutes.
Yes.
If we the decompression around the pseudoarthrosis area. So just my opinion. And recently, I always use the working sheets. So the irrigation fluid is very clearly the drainage out. So also the working sheets also decrease the intra-abdominal fluid collections. In my opinion, that is very important.
Thank you. Thank you.
So, however, if patient has sometimes complain just of abdominal pain, however, just wait and just do the pain control using the analgesics. In my case, is no problem. Okay.
Okay.
Anybody for any questions for Master Son? From the audience, anybody would have any pending questions that they would like to direct to Master Son before we start the next program? Then can I go ahead with the screen sharing and start my next talk? Yeah, that'd be nice. Just give me 1 second. Yep. Yeah, now this is my talk on fluid management in UB. It's quite a simple talk, but it deals with a lot of physics. So I hope you all have a cup of coffee ready and we can proceed. Now, all spine endoscopy basically is a fluid dependent endoscopy. And the fluid medium that we normally use is only normal saline. A height of inflow is usually 1 arm's length above the operating surgeon's head, that is the maximum. And we try to avoid using a pump, but some of us are addicted to the pump. And because pump gives me additional pressure whenever I feel that I have some bleeding. So I set the pump pressure usually at around 25 mm of Hg. Epidural venous pressure usually does not exceed 15 millimeters of mercury. And if the abdomen is free and taken care of when you are adjusting the patient, then you really do not have a problem in achieving hemostasis. Now, one of the most beautiful things about the UB is the semitubular retractor. You can see the semitubular retractor. It helps to make sure that there is an adequate egress of fluid and prevents severe buildup of fluid and pressure. Now, this is a question asked by one of the participants. So this is where the semitubular retractor makes a big difference. Next slide. Just 1 second. Just 1 second, there is something wrong. Yeah. Now, if you see in this third slide of ours, I have marked out the portals. These are the usual scopic portals which we use for the ingress of fluid. The scopic portal is where you connect the fluid, and the walking portal, which I shown in the diagram, is through which the semitubular dilator is there. And this semitubular dilator is allowing the egress of fluid to occur. And We will go to the next slide. Now, what are the advantages of a fluid medium in UB? Basically, it is constant irrigation, very clear vision, excellent scopic magnification. It's literally like we do oil immersion in laboratory microscopes. Why do we use oil as a medium? Because oil gives a very, very transparent clarity to the microbe that we are seeing in the laboratory microscopes. Air is not a very convenient medium. And here we are replacing oil with our normal saline. So it's an excellent scopic magnification under a fluid medium. Now, what we have to understand is the fluid mechanics that are to be understood. And if we understood these fluid mechanics, then we can achieve hemostasis and prevent major blood loss from occurring during UB. So what are the things that definitely create the problem? So one is you need to have proper pressures to help you elevate and float the paraspinal muscle off the lamina, creating a working chamber. And coming to the disadvantages, excessive pressure by pump or gravity can result in a severe headache or intraoperative rise of epidural pressure, especially if you are doing it under an epidural awake anesthesia. So patient will start complaining of pain in the neck and then subsequently pain in the head. Patient can convulse on table. And in many of my patients, I've noticed that post-surgery, there is a bit of numbness in the sacral region. Something I would say like a paracoda kind of a situation. And these patients, they gently recover over a couple of weeks. That numbness goes away. But I found that this happens especially when I use the pump and I use excessive pressure. Temporary blindness due to cerebral edema is also known. And this happens because fluid passes through the epidural space right up to and affecting a cerebellar edema. That is where our visual cortex is. So there is a reported case of this nature, though I have not personally experienced anything like that. Retroperitoneal collection of fluid with severe pressure, a collapse of IVC, resulting in poor cardiac filling and even death has been recorded with fluid in endoscopy. I will not use the word UB, but with fluid in endoscopy. So one needs to be careful. Patient can have some abdominal distension and discomfort. And if you suspect that, then please do an immediate abdominal scan. Try and realize what is happening there. And you can use furosemide and other things to move the extravasculated fluid back into the vascular system and get it out through the kidneys. Next. What is happening here? Again, my slide is, yeah. Now comes to the most important part of what I want to talk about today, is that any fluid basically is affected by two things. One is hydraulics, and the second is hydrodynamics. Fluid is governed by these two major laws, the law of Pascal's and Bernoulli's principle. And we cannot afford to ignore these. So now my next talk, I will be playing it for you. Hi, good evening all of you. Welcome to a small little tutorial. We are today going to talk upon the principle of using fluids in posterior spine endoscopy, whether it be in UBE or in PSLD. But principally, we are going to focus on UBE. The most wonderful technique to have originated from South Korea. And it's my honor and pleasure today to have with us Master Son, who is the originator of this technique. And today I'll be talking upon the principles of fluid management. Now, before we start, I'd like to just draw your attention to this diagram. Now, it's a very silly diagram, but as you can see, I've drawn the spine over here. This is the sacrum in the vertebral bodies. These are the lamina, spinous processes. You can see a scope over here. Scope is connected to a fluid column. And you can see our half-shaped retractor, okay, a semicircular retractor, which is allowing for egress of the fluid which is coming from here. We have fluid coming from here. So fluid is coming through this pipe, it is coming through this scope sheath, and the fluid is coming out from here onto the patient's back and then back into a drainage system. Let us draw the drainage system here. So fluid is going in here. So basically we are dealing with Fluid. Now, what is fluid? Our concept of fluid is something which is like water, is something which is shapeless. It is something which is very gentle. But believe me, it isn't. Fluid which is in a contained system, is uncompressible. It is solid. It is like a rock. Now, when you apply force to such a fluid, that force gets transmitted, and by what we know as Pascal's law, it gets multiplied. Now please understand one thing. You have a small jack in your car, and your car's tire is ruptured, punctured. What do guys? You get out of the car, you remove the jack, you put it below the running board, and you start winching it. What are you doing actually? You are applying a very small force when you winch it. But because there is fluid in a hydraulic system there, that force is being multiplied thousands of times to lift a car which is of 2000 kgs off the road, allowing you to change the tire. Can you imagine 100 years ago when you didn't have the principles of hydraulics and you didn't understand hydraulics? You would have required people with coming in with huge bamboos, bullocks, trying to lift the car for you to change your tire, which you can do effortlessly today. So what are you using? You are using the principles of fluid transmitting force in a contained environment. Now, why am I going into this? Because I will be demonstrating to you that when we use fluid in UP, we are using it in a contained environment. In a contained environment, we do not understand, but to obtain hydrostasis, to obtain hemostasis, we are increasing the fluid pressure within the back. And this fluid pressure, once you have done a phlebectomy and exposed the spinal cord, that pressure is directly hitting the spinal cord. If you do not control the pressure, you will end up with various problems. The patient can convulse and bleed. You can have dissection and fluid going right up to the brain through the epidural space. You have collapse of the epidural veins. You can have collapse of even the segmental artery supplying to the brain or spinal cord. You can have paraplegia. And I recently saw a post by Dr. Kamte clip which showed even air being sucked into the brain. So guys, managing the fluid well is the key to a successful surgery. So coming back to the Pascal's principle, you'll have to follow me and come a little closer. Now, when you apply force, now how do we apply force? See this. This is a continuous chamber. This is your IV fluid. It is at a height, so you have gravity giving it a force, okay, which is about 100 centimeters above my head, okay, and gravity is pushing that fluid down, plus height is adding to the force of that fluid. Now it is in a contained chamber. It is pressurizing a tubing. So this is the IV bottle. It's pressurizing a tubing. The scope here which I draw is literally the bridge between the chamber, two chambers. Now what are the two chambers? The chamber is the space that we have created below the paraspinal muscles. When we go in, we do the dance of the chopsticks and we create a space. We use the Indian knife. We create space. We lift the paraspinal muscle, guys. Now, having lifted that up, you have created a reservoir. Here, your tubing and your scope is the reservoir number 1 bridge, and reservoir number 2 is the paraspinal muscle. Your IV fluid is causing the pressure down, so that is F1 pressure. That pressure is being distributed over an area A1. A1 is a small pipe. Please understand that. IV fluid pressurizing into a small pipe. The pressure is now immense. That pressure in a contained system is going to get transmitted. So what have I written here? Force applied in a contained incompressible fluid pressure increases equally in all directions. So this force is getting multiplied and it is coming here. Now, how do I calculate this force F2? I calculate it is by the area of the tubing. The tubing size is so small. So it's so many small millimeters per area. Now that is getting transmitted into your back chamber, which is a few centimeters. So therefore I've shown it a little bigger. So millimeters becoming bigger. Now what is the formula? The force F2 is the component of the area A2 divided by the area, this area A2, the chamber size you created, by the size of the tubing, cross-sectional size of the tubing, pi r squared, into the force F1, that is your height and gravity. So the height and gravity which is causing force F1, if you divide this area 2 by area 1, multiplied by the force F1, you will realize that F2 is many times the size of F1. So this small fluid pressure, which you think is just a small IV bottle and I just connected it. Oh guys, there is a massive pressure buildup that is occurring inside and it is pushing up the paraspinal muscles. It is creating a chamber. It is creating a well. And that pressure is bleeding control. When you have done the flarectomy, it is compressing the vessels, it is compressing the venous plexus. It's giving you a clear visual field. Now, what happens is patient's BP spikes. The bleeding increases in your visual field. What do? You use a pump, or you ask your assistant to manually squeeze a chamber and you increase the pressure further. But where is the pressure acting on? That pressure is acting on the spinal cord. Many of you, your experience with UB, many of you are masters, Master Saul over here, who is there with me, and Master Hyodongwa. I think they will vouch for me when I say that many patients do wake up with even a numbness in the sacral area, which gradually resolves. So you are artificially causing a paracorda kind of a situation from which a patient is recovering. You can have problems with the CNS. Control of fluid pressure is the most important key. And that is why this tutorial today is very important for all of you. So based upon Pascal's principles, if you effectively increase the applied force F1, F1 force if I increase the height or I increase the pump pressure, then the force at F2 keeps on getting multiplied. Now this is the principle of all hydraulic systems. You see a JCB that digs into the ground. There's a small hydraulic. Next. What do I go for next? Okay. Action. So now let us start with a practical experiment. Now what is the practical experiment? I have with me here a small IV bottle, not the usual 3 liter bottle with a large surface area. Please understand this. Here there is a small 1 liter bottle with a smaller surface area, cut sectional area, on which gravity is acting, which is at a height, which is just exactly, if you see my head here, you will see that it's maybe 100 centimeters above, 1 arm above. That's it. Okay? I have with me the bolsters over here, and assume that this is the patient's back. Now what do I have over here? I have with me here a 250 grams or a quarter of a kg wax block. Obviously wax floats on water and I want it to float on water, but it has its weight. So it is pushing down. Now, what have I done? I have loaded it down. I have connected fluid from below. I assume this is the patient's back. And I have added fluid, colored fluid into this pipe. Okay? Now, my scope X I explained to you over there is like a bridge. So the scope is ready over here. The entire tubing is in front of your eyes. Okay? Now what am I going to do? I'm going to do nothing. Actually, I'm just going to put this fluid on. And That's it. And we are going to wait. Sorry, I have shut it from somewhere. Yes. I'm going to open it. Now that I've opened it, you can see the blue color. You can see the fluid coming into the chambers. You can see it filling up the chambers. Sorry, I'll make it a little clearer for you. You can track the fluid going in. This is the bridge. Sorry, there's a little bit of leakage, so I'm controlling it with my hands. But you can see the methylene blue coming down, and you will gradually see that the wax block, there is blue colored fluid coming from below, and my block is beginning to float. Now what the hell is happening here? We have just created a mechanical space with the Indian knife with our two dilators, and we put in a scope. It is the same scope. It is the same simple IV fluid. As a matter of fact, giving lesser pressure area because it's of a smaller diameter. But this is your chamber. This is the force multiplier. And as you can see over here, a larger area, a larger block of 250 grams is just floating off. This fluid is draining and collecting here in a reservoir. So what have I done? I have used the principles of hydraulics. I have used Pascal's law. Now what will be my savior? My savior would be if I remove this and let the pressure come out, which is exactly what the half circular retractor does in UB. It allows the fluid to come up. So it controls the pressure. It will push the block deeper. It will allow the fluid to rise up above the block. Now you have to learn to manage this balance. How much fluid has to come out through your semitubular retractor system, and how much fluid is needed inside to keep the block floating. Now this is the key element of understanding the fluid mechanics of UB. I hope my demonstration makes you understand that fluid is a weapon. It is as hard as steel. If you are going to use it the wrong way, it is going to crush your spinal cord. If not, and if you still not understood, please go back, please study Pascal's law, please try and understand its application in all fluid endoscopy. I hope my little demonstration has been of some use to all of you guys. All I did was remove the stopper. Thank you very much. Have a nice day. Good evening. We are now going to start the second part of our lecture on physics and principles of fluid management in UP. Now, what is the second part? The second part relates to the Bernoulli's principle. Well, what is Bernoulli's principle? Bernoulli's principle is a principle that governs hydrodynamics. Pascal's law, it controlled hydraulics, that is transmission of force. But Bernoulli's principle controls the dynamics of the fluid movement. Now, what does it mean? What is the relationship? What is the relationship between velocity or speed of fluid and pressure of fluid? These two are inversely proportional to each other. Where speed is high, pressure will be low. When pressure will be high, speed will be low. So they are working directly at cross purposes to each other. Now, when you enter here and from here, let us say this is your scope tip. This is your scope. Fluid channel is attached here, tubing, and fluid is coming through your scope channel and it is coming out here into a chamber. A chamber. What have you created this chamber? You have lifted up the paraspinal muscles and you created a chamber. And you have created an egress system, an outflow system with a semitubular retractor. Correct? This is what you discussed. Now, if the flow is here, is high, if the velocity here is high, the pressure is going to be, velocity is increased, then the pressure here is decreased. But when this fluid comes into an adequately sized chamber, which you have created, adequately sized chamber, please listen to my words, then the speed of this fluid is going to drop and the pressure in the chamber will rise. Now, this rise of pressure is what is going to control your bleeding and give you hemostasis. So, you require to have an adequate chamber. What will happen in that adequate chamber, like I explained? The speed here in this chamber, your speed is going to be dropped. So the velocity, that is velocity or speed, is going to drop, and pressure is going to rise. Now this will help you. This will help you achieve hemostasis here. After this chamber fills up, achieves of adequate pressure, you will have outflow fluid here. So fluid is going to come out through your retractor egress channel. Now, if these two channels are balanced, again the fluid will pick up velocity here or speed, E or speed, will again pick up here and pressure will drop. 3 down arrows. So, what have you achieved? You have pumped in fluid, you have filled up the chamber, you achieved hemostasis, and you are allowing fluid to come out in the same graded manner. Now, this is why it is very important to have two balanced cuts. Sometimes when we are a beginner in UP, we are a little scared with our working instrument, we are uncomfortable, and we tend to use a larger diameter and a larger channel. That's fine, makes your instrument going easier. But what does it do? It disturbs the dynamics, the hydrodynamics of the system. Now what does it do? Assume that this bugger, this outflow channel has become bigger, it's become thicker, huge, hole is big. So fluid is coming in with an X velocity, low pressure. Over here, it tries to develop hemostasis. But because this channel is large, here again the velocity will then, in a large channel, what will happen? The velocity will drop. And therefore, again, pressure will build up. Now, what will this happen over here? This will start forming eddies currents. You will have formation of whirling currents. And this will increase the bleeding. Now, if the bleeding increases, what is going to happen, guys? Loss of vision. I'm in trouble. So, when we are doing a normal UP, please keep both your ingress-egress channels balanced. Fluid going in, fluid coming out. The balance is to be there. Adequate chamber size is to be there. Assume, now one more scenario. We go to scenario 1, then we went into a scenario with a big channel. Now we go to scenario number 3. Now what is scenario number 3? I have been miserly. I have not created adequate space. So what happens? In flow channel, my chamber is very small, and then again the outflow channels. Now, if this chamber is very small, then what is going to happen? High velocity, high velocity, high velocity. I don't build up pressure at all. Now, if I don't build up pressure, what will happen? It will keep on bleeding. So, if your ingress-egress channels are of the usual 3 mm cut, you are sure that your pathways are clear, but you are still having bleeding and visualization problems, please think, maybe, just maybe, I have not elevated the paraspinal muscles adequately. My chamber is falling small. So there is a high velocity in the chamber, and therefore there is a low pressure in the chamber. So this is scenario number 3, which contributes to bleeding. So now we go back and we revise all the 3 steps. Velocity and pressure are inverted. When I have a high velocity system flowing through, as it comes into an adequate sized chamber, it fills up the chamber, drops its velocity, increases the pressure, controls bleeding, and then comes out through a normal sized egress channel. I have made a channel large to try and, make my instruments more easy to manipulate. Especially when I'm trying to do a fusion, I'm trying to put in a 10 mm dam cage. So I have made the channel large. Moment I make the channel large, my visual field inside will start bleeding. So what do? I make my assistant pinch the channel, or I put in a gauze piece there, or I put in a stapler after I put in my cage to the particular depth, just above the spinal cord, so that I can gently retract and push my cage in front. But at that time, I want bleeding control. I want visualization comfort. So I externally control the flow rate. Moment I control the flow rate, the pressure in the inner chamber rises, the bleeding and hemostasis comes up. So in UB fusion surgeries, you need to control the size of the egress channel once the cage has been partially put in. That is one. Now, second thing that I explained to you is, if you do not have an adequately sized chamber, then the velocity of the flow will be sustained. It's like water rushing through a pipe, going from here and there. It's same velocity and same speed. So therefore the pressure remains constant, which is low pressure. Therefore bleeding will keep on occurring. So if your ingress-egress channels are equal, mark my words, if they are equal, but you're still having bleeding, it means that your chamber size is not adequate. You've not adequately lifted the muscles. Go back, introduce the Indian knife, put in your dilators and try and create more space. Okay? I think that about covers what I wish to talk today upon the principles of hydraulics. That was Pascal's law we spoke about, and subsequently we spoke about Bernoulli's principles, how hemodynamics is going to influence bleeding, the relationship between pressure and velocity, relationship between gravity, pressure, and transmission of pressure through fluid medium. All these things factor in when we are dealing with spine endoscopy. I think I have troubled you all enough, and I think I will end my topic here. So thank you very much. If there are any questions, you're welcome to ask them. Master Son, I hope you enjoyed the presentation.
Oh, very, very impressive, very good presentation.
Thank you.
I have two questions. So
yes.
Your chamber is small. Oh, good idea. But okay, you are teacher. You are teacher for beginners.
Master Fonson, the first thing that I will tell you is that laws of physics don't apply to you. You are a genius.
Sometimes in conventional surgery,
Yes.
spine beginners, if they have small operating field, operating procedure is very difficult.
Yes, sir.
Same concept. So in hemodynamics, small chamber is very good idea. But in beginning period, if beginners have a small chamber, I think operating procedure is so difficult.
Yes, sir. I agree with you.
Okay, second question. So how much volume? Volume, how much do you think monkeys?
I cannot really classify on the volume part of it because that is something that we all develop with our skill. How much
Okay.
muscle we lift is something that after your first 5, 10, 20 surgeries, your hand sets. Today, when you do the surgery, you don't think how much you will need to do. It just comes automatically. But when we are doing it, and in our initial stages when we are doing it, we need to be a little more cautious and a little more aware. So if we feel that the chamber is less, if the bleeding is not being properly controlled, then go back, lift more, control the bleeding better, use a little more cautery, and try and get a better hemostasis with the least pressure possible. With the least pressure possible. That is the main aim of the whole thing. So that you have less pressure coming on the spinal cord. Especially, and my other thing that I would really like to recommend is to finish the bone work. Try and finish all the possible bone work before you open the flavum. The base of the spinous process, the opposite side lamina, all the undercutting of bone, try and finish keeping the flavum as a barrier between the spinal cord and the bone. So try and finish the bone work first before you strip the flavum, because once you strip the flavum, then the pressure is directly on the spinal cord. Then there is no protection. So the whole aim of the game is understanding the pressure mechanics and using the minimum pressure possible. So, and that is one thing that I have learned from you. So I'm grateful to you for that, sir.
Second question. So you and I am teacher for UV beginners. So I want to make simplification. So the location of fluid bag is very important.
Yes, sir.
So your presentation told me the level is the one arm overhead. So
yes.
I recommend you only head side, my height. So my height roughly operating the distance head to operating side 50 centimeter converted by 34 millimeter mercury. So I want to simplify the level of the fluid bag. Your head, my head, beginner's head, everyone head level is more accurate, more small pressure I want.
I understand, sir. That is a much safer pressure level. Yes, sir. I agree with you. Okay. Thoroughly agree with you. I use a little more.
Yeah. Good presentation.
Thank you. Thank you, sir. Anand, anything from your side, sir?
Yes, I would like to say a few things. First of all, you said that under low pressure, you try to finish off all the bone work before opening the ligamentum flavum.
Correct.
But as we all know, in all kinds of endoscopic surgeries, the real issue starts when the ligamentum flavum is open. And
yes.
when the epidural venous bleeding starts, and then it clogs our field. And that is the time when we really require to elevate the pressure of the fluid. So any tips regarding that? And secondly, I would like to know, what about use of suction devices? Especially we have shaver with suctions, we have nowadays RF with suctions, or a simple suction tip. When we use these devices, does it change any fluid pressure dynamics?
It does help in the sense that you have a semi-tubular retractor, and as far as the cautery or as far as the shaver concerned, I do connect a fluid egress channel there, but I do not give it suction pressure. Whatever fluid comes out by its auto pressure from within, that is acceptable to me. That it is like a safeguard that should the semitubular retractor not keep the channel open, because my cautery is there and the cautery is connected to no negative suction, just a suction pipe. Pipe is connected. It allows the excess fluid to pour out. That's all. We do not use any negative suction pressure moment we enter inside, moment you strip the phlegm. Yes, from the epidural plexus, there sometimes are bleeding points, which I think Master Son's one lecture is there, and which he had pinpointed that there are 4 points for bleeding. And you need to control those 4 points. You can use, you have a very fine point, a tip pointed cautery, upward pointed pointed cautery, which you can use. You can lift the epidural venous plexus, press it against the bone, and gently burn it there. You can use bone wax. You can crush with your own Kerrison Rounger the bleeding points that are there from the bone. So the bony use can be controlled. And this is how you eventually get a much clearer feel. It's a patience game, and you cannot lose your patience when you're working over here. I think the one very important feature that a endoscopic spine surgeon should have is patience. Master Son,
Okay.
I remember your assistant telling me, you climb the stool, you get down from the stool, you climb on the stool, you get down from the stool.
No, most of the times the issue arises when there is some complication while you are operating, especially if there is a dural tear and you still have to complete your decompression surgery. And these are the times when fluid pressure can cause havoc because you have not completed the surgery and you have some dural defect which is transmitting your fluid pressure intracranially, intraspinally.
That is the time that you have to really drop the fluid pressure, move away from the dural defect, try and complete the rest of your surgery. Or you can use, what do we use? It's like a foam.
Okay, Dr. Malcolm.
Yes, sir.
Dr. Malcolm, so many doctors ask to me for 2 points. First, bleeding control. Second is dural tear. So, Dr. Kevi also dural tear.
Okay, yes.
Bleeding. That means here, I think there are four groups to bleed. First,
Yes.
First, above lamina, I mentioned the three bleeding artery, superior articular artery, inferior articular, interarticular. First, above lamina group, first group. Second group, bone oozing. So, controlled by wax and Bomex. Third group is epidural venous fluxus. So, so I think only upper 3 point, upper lamina 3 point, lower lamina 4 point. So epidural common epidural bleeding point you must learn. Finally, final 4 groups interfascicular, muscular or interfascicular bleeding. So above lamina, bone and epidural and interfascicular bleeding 4 groups. So
Very true, sir.
Next time I lectured how to make clear operating field. Okay, so also the one afraid of the beginners is dural tear. I asked how to repair. I already answer how to prevent. That means here.
Most important is prevention, but it has happened to me, and actually in one of our PSLD programs, even in the cervical spine, we had a dural tear.
Yes.
So we use TacoSeal. We put a TacoSeal patch over there and we keep on pressing up, crushing the dura on it. It gently sticks over there. And otherwise, you can use a dural stapler. You can do a dural suturing if you wish to. But like what you mentioned is that it is at the upper laminar and lower laminar edge where the epidural veins bleed the most. So you need to put in a pointed cautery, lift it up, pick up the epidural vein, press it against the bone, and then burn it over there.
No.
My bleeding.
Malcolm, so we must change the paradigm. That means here, we commonly use Keris launcher, punching by punching, punching, punching.
Yes, sir.
Multiple touch, multi-punching have a high instance of dural tear. I don't use Keris launcher, only elevation.
Only
That means here, so we must change the paradigm. If you afraid of dural tear, you must change your concept.
Correct.
So don't use Keris launcher, only elevation, finished. So again, only, okay, how to prevent the dural tear is the only elevation, no usage, less usage of Keris launcher, okay?
Very true. It is the Kerrison ronger which usually causes the dural tear. And stripping the phlegm is a far safer procedure rather than using a punch to remove the phlegm. I thoroughly agree with you, sir. Thoroughly agree with you. Kavi, I hope that answers your question.
Yes, wonderful discussion.
And I think it's time for you to start your presentation. So can you please share the screen with us?
Yes.
Next.
We have Dr. Anand Kavi speaking to us now.
So at the outset, I would like to congratulate and thank everybody for joining us at this meeting. Respected Professor Son, Dr. Choi, Dr. Dongwa, and Dr. Malcolm, and all my colleagues from around the world and India. So I welcome you all for this meeting. I will also like to congratulate Dr. Malcolm for a very speedy and wonderful recovery from his COVID-19 infection. So wish you all the best. And this is a great effort that within a week's time you have put up this webinar. Starting with my presentation, it's a very simple and basic presentation. I would be speaking on UB instruments. These are the specialized instruments what we usually use. So now we will see the different instruments in sequence as they are used in the surgery. So to start with, these are the set of dilators and different sheaths for the working portal. They come in different sizes from 5 millimeters, 7 millimeters, 9 millimeters, 11 millimeters, and 13 millimeters, and to a maximum breadth of 15 millimeters in case of fusion surgery. Just a sec.
You'll have to restart, I believe. Yeah.
Yeah. Okay. So once we make the incision, this is the next instrument which needs to be used. This is a muscle detacher, and very wonderful presentation by Malcolm regarding the chamber formation and regarding the pressure of the fluid. So this is that important instrument which needs to be used. This is a T-shaped instrument with a blunt tip, and it is used to clear the soft tissues over the working area. It is worked in the intermuscle fascicle space of multifidus muscle, and it is first used over the upper lamina, then we use in the interlaminar space, and then in the lower lamina. And with this instrument, we try to scrape the soft tissues and the muscle layer so that when we put our ports inside and start the fluid, the whole muscle layer is elevated and there is a fluid chamber formed below the muscle layer, which can be explored for endoscopy. So once we have made a working port, we use these kinds of soft tissue retractors. It functions as a semitubular retractor and it serves multiple purposes. It keeps the working port open. It helps in triangulation of scope and instrument. Then it maintains the continuous irrigation output, which is also have been talked about. And it guides the instruments and it also helps in retracting the soft tissue away from the midline. So this is again a wonderful instrument which is specifically made for the UBE surgery. Then this is another modification of the soft tissue retractor. This is a root retractor which has a finger-like projection at the tip, and it is a site-specific instrument. It is helpful in retracting the root and the thecal sac to reach the disc annulus for various purposes. Now coming to the endoscope and sheath. So according to the surgeon's preference and according to the demand of the surgery, we can use a 0-degree as well as 30-degree endoscope. This is a 4 mm endoscopes which are used, and the length is around 180 millimeters. Now this endoscope glides inside the irrigation sheath of around 150 millimeters length, and the sheath is around 6 millimeters in diameter. The initial scope portal is made by inserting a trocar and a sheath together inside. Now, this is another important instrument which has to be used during UB surgery. This is a radio frequency probe. Different makes and different companies make it. It is around 150 millimeters in length, and it is basically used for soft tissue clearance and hemostasis. Because initially when you scrape the muscle and soft tissue around the spinous process and the lamina, you get a lot of bleeding. And to get a clear view, you need to use the radio frequency probe, especially in the initial part of the surgery. You can attach it to radio frequency generators. Usually it is the 4 megahertz generators which are used. But recently there have been higher frequency generators in the market, and also few radio frequency plasma devices, which are again more advantageous. Then the next step, once we have cleared all the soft tissue, we come to the bony edge of the upper lamina at the spinolaminar junction. And then we start burying and shaving the bone and soft tissue at the spinolaminar junction and the upper lamina. The most commonly used instruments, the motorized burr instruments, are the oval or round tip burrs with size of around 4.5 to 5.5 millimeters in diameter. Just now, Dr. Son mentioned that we have to change the paradigm, and instead of using more of Kerrisons, if we use these hooded burrs more often, our job becomes very easy. We get a very smooth bony margin with these kinds of instruments. The issues with bleeding and issues with unintentional dural plucking is reduced with use of these shaver and burrs. Now next comes these specialized double-ended retractors. These are a set of instruments numbered from 1 to 6. These have a very flat tip of 3 to 4 mm and sometimes 5 mm in size, and they have different angles: 5 degrees, 15 degrees, 25 degrees, and 35 degrees curve. They are very useful in detaching the flavum ligament and separating the neural tissue. They are especially very useful in breaking the adhesions around the roots, and they can also be used to apply bone wax in case of bleeding sinusoids after the bone cutting. Next, we come to the suction tips and irrigators. They are with different angle. These are used to remove the bone dust and floating soft tissue debris so that it prevents clouding. They are also useful in irrigating the inside environment of the disc and removal of floating disc fragments, also the debris from the disc. Now, this is another specialized instrument. This is a disc shaver. This is used for disc preparation in case of attempting endoscopic fusion. It is also used for sizing of various cages and other purposes. Then these are specialized UB osteotomes with straight and curved geometry. They are used for removal of bone and osteophytes and preparation of cage bed especially in case of UBE fusion surgeries. Now, another specialized instrument, specially modified for UBE, these are end plate tremors. So basically they have a spade-like tip and it has a very sharp edge with 3 different angles. It is used for scraping the end plate and preparation of end plate for a better fusion. Yeah. So next instrument is this bone graft funnel. It is used for bone grafting during fusion surgery. And then another specialized instrument, this is a bone graft impactor. And there is a similar instrument which can be used for a cage placement in case of UB. Now, other than these, there are routine instruments like Kerrison rounders from 1 mm to 5 mm. They can be up biting rounders, down biting rounders with a 40-degree or a 90-degree cutting geometry. And also you can use different types of disc forceps, either with a cup or serrated jaws from 2 millimeters to 4 millimeters, either straight one or curved one. So basically these are a small set of instruments, and other than this, it is like a routine open surgery. So it is a endoscopic assisted micro open surgery, I would call. So it is a very versatile surgery, and the best part of it is you can use lots of routine and modified instruments into it, which brings down the cost of the surgery, as well as it increases the efficiency of surgery, and it makes it very speedy, especially when you have to tackle a multi-level lesion. I think this is a wonderful technique. So thank you very much, and thank you for patiently listening to my short presentation. Over to you, Malcolm.
Thank you so much. It's been wonderful. Last 2 hours, I don't know where they have gone. We had a great presentation from Master Son, followed by Dr. Hua, and now from you, Dr. Kavi. For the participants, if you have anything that you wish to ask me, you're welcome to unmute yourself and ask a question. And I'm really grateful to all of you for having participated. Yeah, anybody with a question, please?
Sir, I have a question. Malcolm, sir. I hope you can hear me.
Yeah, welcome, Varun.
Yeah, sir, very nice presentation from all the masters. I have a question regarding the radio frequency which we are using for coagulation. Do we need to use these specialized radio frequency probes in UB, and or can we use those same radio frequency 4 megahertz which we are using in the normal underwater endoscopy procedures?
You will require a little bit of a different probes also, because like how Dr. Kavi showed you, he showed you a curved probe that was semi-curved at 45 degrees. You have a hook tip curve or a ball tip probe, which we use for when we have to strip the dura of the epidural veins, fat over the dura, gradually burn it. So that time you really require a very good radio frequency machine. It would drop the power to so low that it takes time to actually even coagulate a vein. So accidentally, even if you touch the dura, nothing happens to the patient. Most of my patients who I now do, I do under epidural. That too, I do under partial epidural, means I do under only a sensory epidural block, not even a motor block. So believe me, when I go close to their cord, and even if I touch it, the patient tells me, sir, I'm feeling warmth in my leg. I can ask the patient to keep moving his legs, check movement on the table. So it's like live neuromodulation occurring all the time. So you will require little different probes that what you use in PELD, what we use in transforaminal. We use that. Definitely you can use that in the facial plane, in the muscle plane. You can use it for the outer tissue just above the flavum, interlaminar tissue separation. So you can use it over there. You can use it on the bone to create your bone docking site. But eventually you will require what we use in arthroscopy. What we use in arthroscopy, you will require those types of instruments.
So, So what I meant was the same generator for the
the
other
generator
thing would
is-
work.
Yeah. 4 megahertz is good enough. 4 megahertz generator is a wonderful generator. When you're close to the spinal cord, I use it on a power of around 4 or maybe 5. And when I'm away from, I'm in the muscular plane, I can use the generator even at 40, even at 60. If I want to control the bleeders that are what Master Son mentioned, the bleeders which are occurring along the facet joint, the superior.
So we don't use the arthroscopy generator.
No, I don't need to use arthro. I need to use a proper endoscopic spine set.
Okay.
But then
Thanks for the answer.
it is common for PSLD. It's common for you. So we can use it everywhere. Not an issue.
Hello, thanks.
Yes, sir.
Good evening, sir.
Yes, welcome.
Good evening, Dr. Malcolm. This is Girish from Jaipur.
Hope you enjoyed the presentation, Girish.
Sir, which is the ideal case to start the UB technique? Means the L5S1 or the L45 or the paracentral or the central or the foraminal disc? Which one is the ideal case for the beginner?
Ideal case would be an ipsilateral disc at L45 because it is a little easier than at L5S1. At L5S1, the L5 root is a little more horizontal. So you have, and it's a little more in the upper plane. So you need to be a little careful when you're dealing with L5S1. And the dura there is a little thinner. At L45, the dura is a little thicker, usual anatomy, and ipsilateral targeting of your own disc after undercutting a little bit of the flavum and undercutting a little bit of the SAP, IAP, a little bit of drilling and going lateral to the cord, using your retractor to gently pull away the sample cord, and then going in and removing your disc. So I would definitely advise you as an initial person who wants to take interest in UB to start with an L45 level.
But the sir, interlaminar space is the wider at the L5S1.
Beg your pardon? Yeah, I understand that the space is wider. I understand that thoroughly. I don't deny you.
Yeah.
The L5 root is a little more horizontal. And the dura is thinner over there. So the chances of you having a dural tear in your initial stages, let's avoid this now. You're welcome.
Girish, another tip for you is to start with a left-sided case because here we have to triangulate. There are 2 ports. So you have to hold the scope in your left hand and you have to use your dominant hand for using your working instruments. So it is better to start with a left-sided herniation case. And once you get a hang, then you can try exchanging the ports or you can try to go to the opposite side. So, but L45, L5S1 both are good. Try for a less stenotic where there is less overlap of laminar bones are easy cases to tackle with.
Sir, Vishnu sir, Vishnu from Hyderabad.
Welcome.
Hi sir. Sir, wanted to know for this working instrument, sir, like are the semitubular retractors same as like what we use for microdiscectomy, or are they different, sir? Because it was not.
They're absolutely different, sir. They're absolutely different.
Okay, okay, fine.
These are handheld. You can control the depth. You can actually use it to go right up till the disc and even retract the root in the cord.
Okay, okay. Sir.
So, and they help you to clear and pull away the paraspinal. Being semitubular in design, it helps you for the egress of fluid. So, little different, definitely different. Better.
Yes, that is an important point for the fluid dynamics and maintaining hemostasis. These are specialized retractors and they definitely aid in the surgery. So routine tubular retractors won't do here because the fluid pressure becomes much low.
Okay, sir. Thank you, sir. I just wanted to know if there is any image in this, sir, like which we can see now or something, sir.
Regarding
I am Dr. Wu from Singapore.
I'll send you I'll send you the images of the retractors. Please don't worry. I'll send them to you personally.
Sure, sir. Thank you, sir.
Sir, this is Dapok from Nepal.
Yes.
Can I have a question, sir? Different masters have different landmarks for making a portals. Okay, sir. Which landmarks do you use? Especially, let's start with the discectomy only.
For a simple discectomy, I would advise you to follow the mid-pedicular line.
Mid-pedicular line.
Mid-pedicular line or a little more towards the medial pedicular line. Actually, I would say you initially take your landmark onto the superior lamina. Your triangulation should meet on the superior lamina. Okay. Your landmark is outside. Please understand your landmark, and you see on the X-ray, you're on the mid-pedicular line. From there, you're angulating and you're coming onto the lamina. So you're not going down vertically, you're going obliquely inwards. There's a slight angulation inwards where you're meeting on the lamina. You create your initial space on the lamina and on the interlaminar space.
So how do you guide whether you use the AP film in C-arm?
Obviously, AP film. And in the lateral, you will be on the highest part. On the lateral, you will be on the highest part over here. You will be on the highest part of the facet joint.
Yeah.
Okay. And in the AP film, if this is the AP film, and assume that this is the two eyelets of the outlines of the pedicle, you will be on the upper part, outer laminar line. And from there, you will be coming onto the lamina.
Yes, sir. Yeah, I want to make it clear because you make a line, okay, where our docking point is in the upper lamina in this around the spinous process area. Okay, sir. And the mid part, lateral part is the mid part of the pedicular line.
Correct.
While making a portals, cutting with a knife, how you decide which landmark do you take? While making a portals.
The upper edge of the disc, from there you go 3 centimeters above and you go 3 centimeters below. I showed it in my presentation. I'll just go back to my presentation if you want, and I'll show you that slide. Yeah, can you see the slide?
No, not.
No, sir.
Sorry, I'll share my screen. Sorry, one second. One minute. Where? Yeah. Can you now see?
Yes, sir.
Can you see this? Can you see the scopic portal?
Yes,
can
sir.
You see the walking portal? And can you see that I'm just 2 to 3 centimeters above? I prefer actually not 2 to 3. I prefer 3 centimeters.
Yes, sir. That disc level is a mid part of the disc or the upper part? Which one, sir?
It is. Can you see here? Can you see this picture?
Yeah, lateral. Yes, sir.
Yes. Now can you see here that my scopic portal is exactly in line with the upper part of the disc?
Okay, sir.
Followed?
Yes, sir.
While the walking portal can be in the interlaminar region.
Okay, sir.
Followed?
Yeah.
And as you see that there is an obliquity. There's an obliquity coming towards the docking on the bone. Followed?
Okay, sir. Because somebody takes the pedicular as a reference point, other takes other parts. So that
I'll just come back to you. Give me 1 second. 1 second, son. Yeah. Now what is there is, this is a standard portal for a discectomy.
Yeah.
Now when you want to go paraspinal.
Yeah, that's different.
Then you are going to go 2 centimeters out of the lateral pedicular line, and you are going to dock at the junction of the transverse process with the superior facet, with the IAP junction.
Yes, sir.
That is a different ball game.
Yeah. Yeah, I know. Just I asked for the discectomy. Okay, thank you, sir. Thank you.
Okay, anybody else?
I am Dr. Wu from Singapore.
Welcome.
Basically, my question is, I personally do scope with using pump. So I realized that I've attended several biportal meetings and a lot of people advise against pump. Why I like to use pump is I know exactly the pressure I'm putting into. So may I know why many of the biportal surgeons feel against the pump usage?
I'm not against the pump. Frankly speaking, I also use the pump. So, but it's a question of when you are in a learning curve and you are not confident about your fluid dynamics or the speed of your surgery, and you're going to take a longer time to perform the surgery. Because see, in the initial learning curves, believe me, it used to take me about close to 2 hours. And today I finished the damn thing in about 20 minutes or in 30 minutes. So using the pump is also, it is God's gift to you. Learn to use it wisely. Learn to use it with the minimum pressure possible. There is a small trick to things also in this. When I insert an instrument to cut, when I want absolute clarity of vision, that is the time I transiently increase the pump pressure. Transiently. Otherwise, I keep the pump pressure in the same range as that would be a normal IV pressure. So I use the pump as a weapon to clear the field a little more when I'm taking a bite. Supposing I'm doing contralateral clearing, I'm going under the bone towards the opposite side. I want to cut the SAP over there. I want to osteotomize the SAP tip. And I want clear vision over there. I don't want bleeding to trouble me. Because you are aware of it, since you're doing UB, you will know that when there is at the side of the contralateral exiting route, there is a leash of vessels. You have a lot of bleeding coming from there. You sometimes need to use a lot of radio frequency over there. So that is the time using that little extra pump pressure helps you to do your job faster. But that does not mean you use it throughout. It's like saying when I'm driving a car in the streets of Singapore, you're not going to drive at 120, 180 kilometers throughout. There are going to be times when you're going to drive it slow. So use that slowness and use the speed.
Dr. Wu, there is another reason for that. There is a problem with a pressure pump. It depends on the pressure transducers inside the system, which will transmit the overpressure, and then the pump automatically adjusts. Now, whenever there is some problem with the outflow in a system during endoscopy, the pump may fail to recognize that pressure differences, and it will keep on pumping the fluid and increase the inside pressure, which usually cannot happen with a gravity induced pressure system. It automatically stops, it clogs. So it is more safe than to use a mechanized pressuring device. That's why most of the people, they try to use gravity induced pressure rather than using pressure pumps. That's the answer for that.
But I'm not an enemy of the pump. I'm a friend of the pump.
Okay, thank you very much.
It is unofficial. Okay,
Sir,
thank you.
This principle is applied over the all endoscopic spine surgeries regarding the pump, or it is especially for the...
I would definitely apply it everywhere. I applied everywhere.
Means the transcameral as well as the UBE technique.
Yes, Girish. It is universally applied.
Safety is first. Do no harm. Then it comes everything else. Okay, guys, I think we had a wonderful day. I'm really glad. I'm happy. Namaste from India. Thank you, everyone. Hope to see you all soon in our next webinar. God bless you. Bye-bye.
Malcolm, I think there are some questions coming in on the chat line also.
Yeah, welcome.
I think there is a question from Dr. Muhammad Ishaq. Main difference between uniportal and biportal surgery?
Frankly speaking, really speaking, none. Both are equally adept in the hands of a good surgeon. Biportal has a slight small advantage, is that you have a 4 millimeter scope that can do contralateral work a little much more better. That's all. That's where I think everything ends. Otherwise, whether it's uniportal or biportal, it is basically at a surgical skill level that you will find that the difference is very less. Biportal, yes, because biportal is cheaper instruments.
Yes.
Easy adaptability. So uniportal is a little more demanding, little more specialized instruments. So I guess that is the little difference that is over there. But once you start doing posterior spinal endoscopy and once you really adapt at doing it, believe me, there's a very, very fine difference. Definitely today we are experimenting with something which I'll go on. Apart from the 0 and the 30-degree scope, there is now a 12-degree arthroscope also. So a 12-degree scope gives a slightly better perception, depth perception when you're doing a contralateral clearing. So that is a little advantage. But beyond that, uniportal or biportal is just basically the same. Little more free hand movement and here a little more restricted movement in the uniportal. But otherwise, I think Dr. Kavi will also agree with me that once you're really good at it, really makes no difference. It's just your mood for the day.
Yes, I agree. Now, today's session is for UBE surgery, but every system has its own advantages and disadvantages. The biggest advantage of UBE surgery is it is more versatile. So you can use your regular instruments also and the short length instruments. So it saves on cost. It gives you more aggressive instruments in your hands to finish off your surgery faster. Whereas in case of single port surgery, it restricts your approach. So you need some more specialized and costly instruments. But advantage of single port surgery in that case, I would say it is still more minimally invasive as compared to UBE. It will less strip the muscles, it will create less injury. You will require to cut the facet less in case of single port surgery. So there are advantages and disadvantages of both the surgeries. Then there was another question in the chat regarding how to identify the dural tear while doing endoscopy. So my friend, yes, this is basically every beginner has this question in mind, that how to identify a dural tear. But what I would like to tell you is because the scope, the eye of our surgeon is very close to the field. So the field is so magnified that in fact, very small dural punctures are also very well visualized in case of endoscopic surgeries. In fact, I would answer it to you in the reverse way. In the initial part of my experience, I was worried that if I leave that dural tear, I may have problems. But later on, I found out that the tear which actually was seen in the scope is so small that even if you leave it, it is inconsequential. So basically what I mean to say is you cannot miss dural tears with UBE or PSLD or any other endoscopic surgery, because the field is very much magnified and you can very well see the defects in the dura created iatrogenically. I think there is another question.
There are many times, I tell you very honestly, many times that I've had small dural tears. And believe me, like we discussed before, one must know how to go about doing one's work with a dural tear, keeping in mind a safe distance and working carefully around it. And at the end of the surgery, just leave it there. Everything just falls back because you've not really stripped or torn or cut or done any major damage. It just seals off on its own. I mean, even trying to staple it or even trying to suture it is, I feel, too much of an effort unnecessarily. I think you agree with me on that.
Yes, fully agree with you.
Personal experience, I think in my few hundreds of cases, I think maybe I've had about 3 or 4 or 5 dural tears, and I just left them be. And they've all done well, excellently well. I told you, like we just discussed that in our last PSLD program, myself and Kavi, we both operating, and we had a cervical dural tear, right on the root, just above the root. We left it. The patient is fine. Nothing wrong with the patient today. Problem relieved, foraminotomy successful. So I don't think dural tear in endoscopy should be a major worrisome factor to most of you.
Okay, there is another question from Ed regarding Dr. Son mentioned to avoid Kerrison Ranger to reduce risk of dural tear, what instrument to use instead. So friend, we use more of burring instruments. We use the hooded burr. So we used motorized instruments to cut the bone instead of Kerrison. It is so that is what Dr. Son meant to say, that it makes it more safer. Another question for you, Malcolm. How much does it cost in rupees to buy a basic cheapest UV instrument set in India from scratch?
I think I will ask all the participants to get in touch with Mr. Praveen.
Or message in private.
Message him privately. He's part of our group. So I think he's the person who will take care of you. It is definitely much cheaper in India than anywhere else in the world. But I guess you can contact him, Mr. Praveen Bundada. He's part of our group today. So please contact him. Anything else? Anybody else on the chat? Any other questions?
No, I think we have done with the questions on the chat list.
Okay, so
May I add one comment on dural tear, sir? May I add one comment on dural tear?
Hello, I didn't get your question.
Yeah, sir. Sir, this is Girish from Jaipur. May I add one comment over the dural tear?
Yes, please do.
Yeah, sir. If in open surgery, even if the dural tear up to the 8 mm, there is no need to repair it.
Correct.
There is no need to repair it.
Correct.
Overall, ultimately the muscles and the fascia falls over that, and the dural tear never creates the problem.
Correct.
And if the beginners are so worried about the dural tear, you can put a Surgicel, hemostatic Surgicel, small piece of the Surgicel over the dural tear. It's far enough.
Correct.
I wanted to add this comment over the dural tear.
routinely use Tacosil. It is now manufactured by an Israeli company, and it's not really expensive. It is, I think, barely 100 rupees for a packet of Tacosil, so that is close to around $1.5. And the moment you put the Tacosil in, it becomes like gel, and it's very easy to just press it gently into that dural tear, and then just gently pinch the edges of the tear. It sticks up. That's it. Even if you wish to, otherwise you can even leave it be. So you need not, you need not fret over it so much. That is little advice to all of you.
Yes, sir. Thank you, sir.
Thank you all so much. Thank you all once again. Thank you, Dr. Kavi. Dr. Bhupesh was joined us quite late because he had a family emergency. So I apologize on behalf of him. His cousin had to undergo emergency cardiac procedure and he could not be here with us today. But our feelings reach out to him, and hopefully we'll have him with us in our next program. Thank you all, everyone. Thank you all once again. I'll end this meeting now. Thank you.
Thank you, sir.